much. This is a similar slide like the one I showed you this morning that shows that these drugs act on the 10A and dabigatran and some other drugs act on the thrombin. And they have come on the market. I'd like to remind you that unfractionated heparin acts both at the 10A and 2A and low molecular weight heparin. And fondaparinux, about which I've talked earlier on this morning, is only anti-10A. Now this slide summarizes all the studies that have been done with the new oral anticoagulant drugs on venous thromboembolism treatment. And with rivaroxaban, we have the Einstein DVT and pulmonary embolism. They have now been published. The Einstein extension studies I will present. With dabigatran, we have this study has been published, and these two are in abstract form, and apixaban has just been published as well. So I'm going to start with the dabigatran study, where symptomatic patients with venous thromboembolism were randomized into the standard treatment of enoxaparin followed by warfarin, while the other half were with enoxaparin followed by dabigatran. And this was a period of treatment of 6 months. And the results show that the cumulative risk of recurrent venous thromboembolism and related death are absolutely the same. There is absolutely no difference. And if you look at the major or any bleeding, this is increased with warfarin, while it's less with dabigatran. And if you look at warfarin and major bleeding and dabigatran major bleeding, there is absolutely no difference. Now we're coming to the second study. In this study, patients who had been treated with conventional anticoagulation for 3 to 12 months had their warfarin stopped, and they were randomized. And here we're talking about a very large study of 2,800 patients. And half of them continued to have warfarin, and the other half went to dabigatran. And the treatment period varied from 3 to 36 months, and this was predefined by the doctors. And in this study, the results were as follows. In this study, if we look at the recurrent venous thromboembolism, it was 26 versus 18, and this was significant for non-inferiority. And it was 1.8% versus 1.3%, so there is absolutely no difference. Major bleeds, we're talking about 0.9 versus 1.8, so there's a reduction in major bleeds with dabigatran compared with warfarin, and this is statistically significant. And of course, any bleeds is 19% versus 26%. There was a problem, though. In this particular study, the acute coronary syndromes, the myocardial infarctions that occurred, were increased compared with warfarin. And this now is emerging as a side effect of dabigatran. So we have to be very cautious. This was an abstract presented at the ISTH meeting in Kyoto. I have not yet seen the publication. So the conclusion is dabigatran is as effective as warfarin in the extended treatment of venous thromboembolism. Dabigatran was associated with a reduced risk for bleeding, but an increased incidence of acute coronary syndromes. Now we're coming to the rivaroxaban studies. And I will start by presenting the Einstein DVT study. And in this study, people who had symptomatic DVT without any pulmonary embolism were randomized, and we're talking about 3,500 patients, into rivaroxaban, 15 milligrams, and then after 2 weeks, we go to 20 milligrams versus enoxaparin followed by warfarin. I'd like to point out that the rivaroxaban can be started from day one. You don't have to give enoxaparin first. And in this study, the first symptomatic, I'm trying to get the cursor, it won't come up. The first symptomatic recurrent venous thromboembolism was 2.1 versus 3%. So there was no statistical significance. But if you look at recurrent DVT, this is venous thromboembolism. If you look at the current DVT, this is 0.8 versus 1.6, and this is statistically significant. This is not in the paper, this is my statistic, I did it. And as far as the other events, there is no difference. And if you look at the hazard ratio overall for venous thromboembolism, it's not significant, but this trend is driven by this significant statistic of the recurrent DVT that was half the rate in the rivaroxaban. So rivaroxaban is of promise. And then if you look at the subgroup analysis, there is absolutely no difference for gender, age, etc., until you come to the duration. And here we have 3, 6, and 12 months. And if you look at these ice bars, it goes there, it seems that if you go on for 12 months, then you get a statistical significance in favor of rivaroxaban, because if you go on for 1 year, you will reduce the number of events by so much that you reach statistical significance. Now, the principal safety outcome analysis, the first major clinically relevant or major bleeding, there's absolutely no difference. The conclusion is that oral rivaroxaban can provide clinicians and patients with a simple, single drug approach for acute and continued treatment of DVT that improves the benefit-risk profile of anticoagulation. Now we come to the Einstein extension study, and this was a randomized double-blind placebo-controlled trial, and we are talking about 1,197 patients who had completed their previous treatment with warfarin. They had either DVT or pulmonary embolism, and they were randomized to get a placebo after the period of 6 or 12 months, or rivaroxaban. And this went on for 6 or 12 months. Again, it was predefined by the physician. And look at the results. There was a very high recurrence rate in those in the placebo, 9% at 300 days, compared with rivaroxaban, with a relative risk reduction of 82%, and the number needed to treat to prevent one primary efficacy outcome is 15, which is very impressive. So here is an answer for what to do after you finish with warfarin. And now we come to the final study, which is the pulmonary embolism study that was published this year in the New England Journal of Medicine. And in this study, people who had confirmed symptomatic pulmonary embolism were randomized into rivaroxaban again, starting from day 1, versus conventional therapy. And rivaroxaban was non-inferior to standard therapy. Symptomatic recurrent pulmonary embolism was 2.2% in the rivaroxaban and 1.8% in the standard therapy. No significance in the hazard ratios. And when it comes to major clinically relevant bleeding, rivaroxaban was 1.1%, standard therapy 2.2%. Again, this is in favor of rivaroxaban. And these drugs have now been registered for prevention. They are being registered for treatment. And there are a number of questions that remain unanswered. And the first one, what is the efficacy in preventing recurrence in patients with cancer? We don't have any studies. What is the evidence in preventing recurrence in patients with thrombophilia? Do we have better recurrentization than with warfarin? This is what we are hoping because we want to prevent post-thrombotic syndrome. And is there such an efficacy in preventing post-thrombotic syndrome? And I've been telling the people who run these big trials that we need 5-year follow-up on the patients to see what happens. And the next question is, does this treatment, compared with warfarin, is it better in preventing pulmonary hypertension? And what is the optimal duration? And I think the next 5 or 10 years,